I've been asked to talk a little bit about research projects involving healthy babies. We've heard lots about all the data that we potentially need to inform decisions about newborn screening, so we need to do some research. I thought first I'd point out where we've been in terms of thinking about the overlapping ethical issues between broader ethical issues in screening. We heard some of the broad ethical principles at the very start of the day, those that apply specifically to newborns, and then those overlapping but also some distinct issues related to newborn genome screening. What I've been asked to focus on specifically is a different set of slightly overlapping issues in terms of newborn research and the overlap between newborn screening. So I'm going to cover, or at least highlight, some ethical issues that we've mentioned during the course of the day, that perhaps not always identified the ethical elements to them. I'm going to say a little bit less about research, but it might come up more in the panel discussion. So in terms of testing healthy newborns, and of course, as has been highlighted multiple times, we're talking about newborns who are not symptomatic by the focus of the day. We had general issues to do with screening, and then specific issues that are related to newborns. Of course, one of the things that's different between newborns and older patients is that somebody else is giving consent on their behalf. If we're going to embark upon obtaining consent either for newborn screening or for research, there's a question about when we might do that. Are we going to do that before somebody becomes pregnant, early in pregnancy, mid-pregnancy, late in pregnancy, after birth? There are pros and cons with those. So there's a spectrum in terms of when, often in terms of the distractions that might influence people early in pregnancy or before pregnancy. People have got lots of time, but it's not very real. When the baby's already there, they have much less time. It's very real, very urgent, but so there are those sorts of trade-offs. And then there are questions about how we engage in the consent conversation, how much detail has gone into. We talked a bit about some of the complexities of consent. I'll come back to some of those shortly. But of course, one of the challenges is we might have a thought, we might reach a decision about when we think is the right time to approach families for consent for either newborn screening or for research involving genomic data, and to approach it in a different way. But when we do that, what we're doing is we're making a judgment about what we think is the right approach. But one size doesn't fit all, because for some people, the right time would have been early in pregnancy, but we've decided the best approach is to do it mid-pregnancy. Other people, the best time would have been, the best thing would have been to provide lots and lots of information, but we've decided that the right approach is to provide a minimal amount of information. So there is this challenge that, again, overlaps between screening and research, that we try and think what's the right approach, but it's not going to be right for everybody. And in terms of the spectrum of information, there's a challenge when we think that we're going to provide lots of information and get fully informed consent about whether that's meaningful or feasible. If we try and provide small amounts of information, there's this concern that the process, either the research process or the screening process, becomes routinized and people just engage in it and sort of passively absorb it without engaging or understanding the information. And there are these interesting questions. Certainly doesn't apply to research, because we usually think research is entirely optional, but there are some interesting questions in terms of newborn screening, particularly if we're focused on the conditions where we think they're definitely a good idea, whether it's then ethical for parents to refuse to embark on newborn screening, and of course taking the risk then that their child will develop a potentially treatable, lifelong, impactful illness. One of the issues, of course, that we've been dancing around all day is the weighing up of the benefits and harms. When we're talking about newborns interventions, or this is in relation to newborn screening, we're talking about the potential benefits of early life treatment, potentially before the onset of symptoms, versus often the harms associated for a larger number of individuals of affecting the relationship at a critical stage in terms of bonding with the newborn. The impact in terms of ongoing anxiety. We've heard about the concern about medicalization of those with an uncertain diagnosis or a genetic diagnosis that might have impact later in life. And of course, the challenge, we've heard lots of desire to reduce the uncertainty, to quantify these benefits and harms. We want the perfect study that's going to tell us how many people are going to be in different categories, but of course we don't have that at present. But one of the important issues which we danced around is that even if we had the perfect study, even if we knew exactly how many people there were of different kinds, there would still be an ethical question about how we evaluate that. How do we weigh up these different types of harms? One of the fundamental issues when we're talking, again, focusing specifically on screening, less on the research, is that we're trying to weigh up potentially many small harms against a smaller number of potentially larger magnitude benefits. From a philosophical or ethical point of view, the challenge here is what's sometimes called aggregation. So do the many small harms add up to outweigh the large benefits, or vice versa? There's an uncontroversial conclusion which we might reach, which is the large benefits outweigh the small harms. We think it's justified to cause some degree of parental anxiety in a modest number of people, but because we prevent a child from having that terrible degree of intellectual disability in PKU. It's more controversial when we reach the opposite conclusion. We say we're not going to prevent the severe disability associated with spinal muscular atrophy because we're concerned about the smaller harms that we might cause to a larger number of people. This is to kind of use a caricature, the weighing up of preventing migraines versus preventing single cases of paralysis. How many migraines is it worth failing to treat to prevent one case of paralysis or one preventable death? So that sort of calculation, and the challenge is that no amount of data will tell us how we should respond to that. And of course, again, to go back to the point that I made before, different people are going to have very different views about how to weigh up those harms depending on their perspective. If you're somebody who's had experience of illness, one of those harms is going to loom very much larger than if you've got no experience of illness and what you're worried about is the false positives. We might take it at an individual level and have conversations about these different possibilities, including the chance of true positive or false positives, the implications and consequences, and of course, again, thinking that it isn't one size fits all, that individuals might reach different conclusions about either whether to proceed with newborn screening or screening for what. So Angus raised the intriguing possibility that we might, if we think looking forward about newborn genome screening, we might separate what we think of as the tests that we would recommend for every new parent and the added extras which come with some degree of uncertainty. I suggested in conversation that we might think about different risk profiles, like the investment opportunities the banks give you. You can talk about high risk, high return, low risk, low return, somewhere in between. So we might have that sort of modified. But of course, if we have those sorts of conversations, the consent conversation becomes much more complex, takes much more time, is less accessible to some within our community who find these sorts of things very difficult to deal with, who have less educational background or less access to English. And when we're thinking about screening programs, again, the temptation is we need something that's quick and easy to administer. That's one of the elements of the Wilson and Young is that it needs to be something that you can easily deliver. But that tends to push us towards, again, a one-size-fits-all rather than something that's tailored towards individuals. Just very briefly, to think about what are the specific issues that might relate to research in healthy newborns. There's a missing Y there. So one of the principles in terms of research, so here now we're no longer talking about weighing up of benefits versus risks, we're just talking about risks. The benefits are elsewhere, the benefits are for somebody else in terms of the way we normally approach risk, the research. Of course, there are some theoretical benefits if some results are returned. I'll come back to that. But the usual principle that applies to patients who can't consent is that only a minimal level of risk would be acceptable. Now that highlights an important question, which is what do we mean by minimal? What counts as minimal? But we, of course, also need to think about what are the risks that might be involved in the research. If it's using the leftover blood spots, it's not going to involve nasty procedures or exposure for the infant, but there are, of course, these potential risks in terms of the data and how that might be used. Clearly, a central issue is informed consent. I've already highlighted some of the challenges of informed consent, and others earlier in the day have highlighted the baseline problem of misunderstanding and misconceptions that influence the way that people receive the information that is given to them. Within the context of research, there is, as many of you will be very familiar, this baseline therapeutic conception that people think no matter how much you tell them that you're recommending this research because it's good for their child or good for them. But of course, that's at least in most cases, not what we're talking about. So we have this underlying misconception. If we're talking about, again, this sort of genomic research, are we going to ask for broad consent that covers a range of different studies? Or are we going to provide only specific consent for something now? If we provide only specific consent, that either means that we then are unable to go back and do further studies, or we have to go back to the parents and contact them. So that becomes then more complicated. Or reduces whether parents are willing to be contacted for further research. There are issues that have been highlighted by Richard about whether the parents are able to withdraw subsequently. There's a bit of a trade-off in terms of if it's possible for them to withdraw, then that also means that their information is potentially more identifiable, or there are greater risks. If you de-identify the information to a degree that you take away the risks associated with it, then it also becomes impossible potentially for them to withdraw their data. And then there are interesting challenges that all of us are just starting to think about in terms of newborn genomes and whether or when we might involve those young people later in life in decisions about whether they wish to remain, their data to remain in those databases. So I'm going to stop there. In terms of projects or screening in healthy newborns, we have this challenge of benefits and harms and concept of minimal risk. The challenge that's specific to the newborn period in terms of the relationship with the child at a critical time, and these issues which we've highlighted already in relation to consent. Thank you very much.